introduce the first session of the day titled The Whole Enchilada. Access Strategic Direction for Whole Person Care with Jami Snyder, Director, Arizona Healthcare Containment System, and Mike Mote, Chief Strategy Officer for Health Current. So, and Director Snyder will be presenting initially as we move forward with this. Director Snyder will provide us with an overview of action related to whole person care, the HIE, into that strategy. Once complete, Mote from executive team will provide an update on our progress related to our social determinants of health HIE strategy. Please join me in welcoming Access Director Jami Snyder to the virtual stage. Director Snyder.
Good morning, Keith. Thank you for that introduction. Am I okay to go ahead and get started?
Yes, ma'am. The stage is yours.
Wonderful. Thank you. And thanks to Health Current for inviting us to be a part of this year's conference. We're really excited about some of the work that we're doing to partner with Health Current related to our whole person care efforts. And so I'll walk through a series of slides and then I'll hand it off to my colleague, Mike Mote, who can talk about a specific project that we're engaged in with Health Current around whole person care. So to get started, next slide. Always like to level set when we do a presentation. So just as a reminder, the Medicaid program in Arizona is the largest insurer in the state, serving over 2 million enrollees. Our enrollment has increased to the tune of approximately 200,000, just over 200,000 enrollees over the course of the last 8 months due to a couple of factors. Certainly people entering the Medicaid system for the first time due to the increase in unemployment, and then also individuals remaining on the rolls, and that's consistent with an expectation of our federal partners that we not disenroll anyone over the course of the pandemic period. So we have seen a pretty tremendous jump in our enrollment over the course of the last 8 months, and we're now over that 2 million mark. As you know, Access uses both federal, state, and county funding to support the program. We support over or provide funding for over 50% of the state's births and 2/3 of the state's nursing facility days. We have over 97,000 registered providers that are enrolled with Access, and we make payments to 15 contracted health plans. As you may recall, we were the last state in the country to join Medicaid, but the first state to establish a mandatory managed care system where we contract with private sector partners and public entities to administer the benefit on behalf of the Medicaid program. Next slide. In November of last year, we officially launched what we are calling our Whole Person Health Initiative, really looking at extending the notion of integrated care beyond the provision of physical health services, behavioral health services, and long-term care supports and services, and looking at those social determinants that can also impact health outcomes. So as stated here, the Whole Person Care Initiative is really focused on those social risk factors that do play a role in influencing health outcomes and looking at options for maximizing our current benefit in order to address some of those social risk factors that can impact those served by the program. Next slide. I'm going to start by talking a little bit about current initiatives within the Medicaid program in Arizona that we're pursuing that address whole person care and, again, those social risk factors that can impact health outcomes for our membership. Next slide. In April of 2018, so some time ago, we began to encourage providers to properly code when they were identifying social risk factors in the context of a clinic visit. So using a series of Z codes to identify those social risk factors. We have, over the course of the last 2 years, 2+ years, collected data from clinicians to look at what social risk factors are really rising to the top for our membership. And you can see here those social risk factors that are most prominent based on the coding that clinicians are doing: homelessness, unemployment, and then a history of physical, sexual, or psychological abuse in childhood. So a good context for our discussion around whole person care, and really that work to collect data has helped to inform some of our work going forward and our areas of focus going forward. In addition to encouraging providers to code and capture information around those social risk factors that are impacting members that we serve, we also, through the support of our state legislature, are able each year to offer housing subsidies, rental assistance, and do some work in the area of acquisition and rehabilitation of properties. You can see here with the dedicated funding, approximately $28 million annually, we're able to house with rental subsidies 3,000 members per month. In addition, we receive approximately $2 million each year to work on both the acquisition of properties and the rehabilitation of properties. All funds, as I mentioned, are state dollars. We don't receive federal funding for the rental assistance or acquisition and rehab activity. And our housing programs are administered in partnership through our contracted health plans, currently our regional behavioral health authorities. And I'll talk a little bit more about a shift in that administration work going forward. We have a lot of evidence of success. I'll give you one example here. Arizona Complete Health, one of our contracted health plan, was able to, through their work in the housing arena, was able to successfully house 152 members. And you can see the direct impact that that work has on health outcomes. Those members, across the 152 members served, we saw a 45% decrease in emergency department utilization, a 46% decrease in crisis utilization, and a 56% increase in primary care wellness visits. So consistent with what the literature will tell you in terms of the impact of social risk factors on health outcomes, interventions that attempt to address those social risk factors clearly improve health outcomes for members that we serve. Next slide. A specific project that we've been engaged in with a variety of community partners over the course of the last couple of years is what we call Project H2, our healthcare and housing project. You can see here we've worked with a myriad of community partners, including contracted health plans such as Mercy Care Plan, Community Bridges, Maricopa County, the Tempe Housing Authority, the Phoenix Housing Authority, as well as the Maricopa Association of Governments and their Coordinated Entry Program in pursuit of this project, which really seeks to successfully stabilize individuals experiencing chronic homelessness in housing long term. The approach required a braided funding model, bringing in funding, existing funding through the programs that I mentioned, but also other county level funding and nonprofit funding to ensure that we were able to provide the necessary supports and services to individuals so that we could stabilize them longer term in housing. Over 100 individuals experiencing chronic homelessness have been engaged through the program, and we've been able to successfully house 62 individuals to date. When you look at the demographic profile of individuals served through the healthcare and housing program, or Project H2, you can see that 98% are chronically homeless, 50% are over the age of 55. The average time homeless is over 10 years. And 75% of those served through the program have co-occurring mental health conditions, substance use disorders, as well as physical disabilities. So it really gives you a sense of the complexity of the population that we're serving through this program, and the tremendous success that we've been able to experience today in successfully housing 62 individuals and stabilizing them in that housing environment, or that living arrangement, through the provision of supportive services, wraparound services, in addition to rental subsidy to support. Next slide. In addition to the work that the agency is doing in the housing arena, our contracted health plans have joined together around a really important effort called Home Matters to Arizona. Our contract with our contracted managed care organizations requires that a portion of their profits be reinvested into the community. Our contracted health plans recently decided to come together to pool a portion of those reinvestment dollars to successfully house or increase rather the availability of affordable housing in Arizona. And there are some areas or populations of focus with the Home Matters program, including individuals and families with low to moderate incomes, veterans, seniors, people who are homeless, people with disabilities, individuals involved with the justice system, and then of course, access beneficiaries. The initial investment on the part of our health plans is $2 million, but the target investment is $100 million. So you can see at the top of the slide, you can see the range of project partners really representing all of our privately contracted, or I should say private sector health plans or managed care organizations. And the project is being supported by the Local Initiative Support Corporation, or LISC, which is providing underwriting support as well as asset management services for the fund. Initial applications have been received. So for that first round of funding, and the group is anticipating an award this month. So literally any day now. So this is a great example of how the private-public partnership within the Medicaid program works to benefit those that we serve, specific to whole person care and those social risk factors impacting our population. Over the course of the pandemic, really over the course of the last 8 to 9 months, we've also been able to pursue some targeted efforts around whole person care. Probably the most notable of which is the expansion of our telehealth or telephonic services benefit. Understanding that members that we serve, like the population at large, upon the onset of the pandemic, were really reticent to engage with their physicians or primary care providers face-to-face. We expanded our telehealth benefit even beyond an expansion that occurred on October 1st of last year to ensure that those individuals that, for instance, don't have access to audio video technology could access services via a telephonic benefit. This benefit has proven to be tremendously useful to members across the state and has really helped us to better understand how telehealth and telephonic services can enhance access to care, not only for individuals over the course of the pandemic, but for individuals living in underserved or more remote areas of the state that are now accessing care with a level of frequency and at a rate that they haven't historically. We also received permission from the Centers for Medicare and Medicaid Services early on in the pandemic to suspend premiums or copays that exist within our program, certainly addressing some of the financial constraints that our membership is facing along with individuals outside of the Access program. In addition, we were able to supplement the work that our non-emergency medical transportation vendors offer in transporting individuals to clinical appointments. In particular, early on in the pandemic, there was a real concern about individuals who had tested positive for COVID or were presumptive positive for COVID that needed to access routine services, such as dialysis or chemotherapy treatments. We were able to establish an add-on rate for NEMT brokers and their associated providers, really incentivizing them to transport those members who are positive or presumptive positive over the course of the pandemic period. So a really important move in terms of addressing some of those transportation barriers that we were seeing early on in the outbreak. We also were able to coordinate with existing vendors to transport individuals post-discharge from a hospital stay. In particular, this was important for individuals served in some of our tribal communities or tribal lands, including the Navajo Nation. Post-hospital stay, it became apparent in certain cases that individuals weren't able to obtain the transport they needed to return to their home on reservation. So we were able to coordinate with existing vendors to ensure that individuals were able to be successfully transported back to their home. And then finally, we participated in weekly care coordination meetings, specifically focused on the needs of members facing homelessness over the course of the pandemic period. We know that that's been a major area of concern across the country and certainly in the state of Arizona. And those meetings have been really instrumental in ensuring that individuals experiencing homelessness were able to access necessary services and supports and obtain temporary living arrangements that would not only protect them, but protect other individuals facing the same sort of situation. So now I'm going to talk, if we can go to the next slide, a little bit about the future of whole person care within Arizona's Medicaid program, within Access. As I mentioned, next slide, as I mentioned earlier, our real focus at this point is looking at what we can do within our existing benefit package to really further support some of those social risk factors or address some of those social risk factors that are impacting our membership. The three areas we're most interested in right now, based on what we've heard from the community, including community-based organizations, and from the data that we have obtained through our coding initiative launched in 2018, the areas that we're looking at are transportation, supported community connections, and housing. I'll start with housing. Clearly, we've done a tremendous amount of work in the housing arena already, specifically because we have resources, state level resources to support the provision of rental subsidies, acquisition work, and rehabilitation work for specific properties. But in the housing arena, one effort that's underway right now is really to centralize the administration of some of our housing activity under one contractor. We released a request for proposals last week, soliciting the interests of vendors that may be interested long-term in administering that housing benefit on behalf of the Medicaid program in Arizona. We have historically worked with our contracted managed care organizations. Our managed care organizations will continue to serve an instrumental role in ensuring that the members enrolled with their plan are accessing housing services and supports. The centralization of that housing administration work will simply allow us to ensure that the housing dollars are getting out the door and ensure a consistent approach across our system to the administration of those available resources. Transportation, another area, as I mentioned, certainly that was clear during the pandemic, an area of need, continues to be an area where we feel like there's tremendous opportunity. So looking at opportunities within our existing benefit to create access to services outside of clinical services, access to or transportation rather to the grocery store, and facilitating the ability of our membership to obtain healthy food, transportation to job interviews, transportation to court appointments, and so forth. So looking at things like enhancing the availability of bus passes for those that live along a bus route, so they could use those bus passes not only to obtain clinical services, but a broader range of services addressing some of their social service needs. And then supported community connections. Along with our partners at the Department of Health Services, we know that now more than ever, the issue of social isolation is a real area of concern for our community. Clearly, because stemming from the pandemic, but more generally, we feel that there's real opportunity, again, using our existing benefit package, looking at the potential expansion of our habilitation benefit to connect individuals, and in particular, individuals with disabilities that may be harder hit by social isolation and lack the necessary resources to connect to the community, looking at using that existing habilitation benefit and offering peer support services that allow, in particular, young adults with disabilities to more easily connect with their community and become involved with community resources and community groups in their neighborhood. Next slide. And one of the efforts that we really feel is foundational to our work around whole person care is the establishment of a closed loop referral system. And I'm going to turn it over to Mike in just a moment. But Health Current has been a tremendous partner as we have looked to implement a closed loop referral system in Arizona. There are a handful of states in the country who have already established closed loop referral systems at a very basic level, and Mike will give you a lot more information on this front. A closed loop referral system will allow a clinician, within the context of their existing electronic health record, during a clinic visit, to identify members or patients' social service needs, to simply use their EHR to properly record that social service need, and then in an automated fashion, that system will reach out to a hub, a referral hub, which can identify the resources that may be available to serve that individual. And then the referral database will reach out to the social service organization or organizations that can serve that individual's needs. And assuming we've obtained patient permission, the social service organization will then reach out to the patient and offer up those critically needed services. And we'll be able to see through the automated system that the individual has obtained the services. So that's the kind of closed loop nature of the system. We see this as a real opportunity to make it easier for clinicians within our delivery system to identify these needs and then to connect individuals to critical social services. And I will turn it over to Mike at this point, but it's my understanding that there is a solicitation underway currently in anticipation of awarding a contract for a closed loop referral system.
Thank you, Director Snyder. Appreciate it. Again, I'm Mike Mote. I'm the Chief Strategy Officer for Health Current. And over the next several minutes, I'm going to take a little deeper dive into the closed loop referral system that Director Snyder just mentioned. What we'll cover, and we're going to look at it from the top down. What can these systems do? How can they be used? And then we'll take a look at the timeline that we're working with Access on and Director Snyder in being able to obtain and deliver that system to the state. And I mean, all providers, all community-based organizations in the state will be able to use this, the status of our project, and what the next steps are. To begin with, we've looked at 8 different systems today, and we are in the process of soliciting proposals for a new system. But all the systems we've looked at and previewed will allow us to establish a healthcare and human service provider directory. In other words, any provider, whether it's behavioral health, physical health, long-term care, hospice, and any community-based service organization that wants to participate and utilize this system will be in a directory. One of the advantages we have in Arizona is that the Arizona 211 program that's run by the Crisis Response Network has already built a very large directory of community-based services and healthcare providers. We're going to be collaborating with them and actually integrate our new closed loop referral system with Arizona 211 in order to start our directory really from one that's been in existence for a while. Once we have that basic directory in place, then those healthcare providers or their service providers, community service providers, will be able to go in and add additional information about their service. This would include their capacities, and that could be by facility or location. their hours of operation, languages that they support, and even eligibility criteria. There are many other elements that can be captured and maintained by those service organizations and those providers. And what that does is then provides the ability for somebody seeking services or providers seeking services for one of their patients to actually look online and see what services are available in the specific area they're looking at, whether it's shelter, housing, food, transportation, both medical and non-medical, utility assistance, employment, education, social isolation services, and even healthcare. So this system will build that directory and make that information available interactively, either through your EHR or through a portal on this system, so that you'll be able to see what is available, what those capacities are, and actually even the neighborhoods. So if you've got a patient that's in Goodyear, you'll be able to see the services that are near that organization or near that community and near that patient. The system will also allow the registration of patients and human service clients. In other words, those seeking assistance will be able to register through this system. That registration will be kept for perpetuity, so that as they come in and out of the service or they need additional services, the system will retain that demographic information. It'll retain their social risk factor assessments that have been done in the past, and will provide you the ability to use any screening tool you want within your system to assess the risk of that patient, and then to pass that information on to the referral system to be captured and acted upon. The system will also capture, code, and display those screening results. So beyond just your screening for your patients or your clients, you can enter that system, that information into the system. The system will, wherever possible, apply national coding standards to it, and we'll work with organizations and the different screening tools like Prepare and others to do that coding with you, so that once that information is in the system, it can be used regardless of the screening material to identify the needs of that patient at a level where it can be acted upon. Once that system is there, once you've entered and registered that patient, you've done the screening, the system will also allow you to create and route service referrals. Director Snyder referred to that early on. And what that means is that a healthcare provider who has a patient like Mike Mote, who has chronic housing issues, will be able to go into the system, record that need, and the system will help them determine which service organization to send a referral to. So it can be a healthcare referral to a human services provider. What we've also found in our studies that human service providers will refer to each other. So Mike Mote, seeking shelter tonight, is also looking for long-term housing, is looking for food subsidy, is probably looking for employment. Those human services agencies will refer to each other, so that that initial referral from that primary care provider literally can start a chain reaction that is tracked and monitored by the system and reported back to that physician on all the activities that that individual, Mike Mote, is going through and where it's going. So besides doing the referral, the system will also track and provide alerts on each phase of that service and that referral. And it would, for example, will provide, if the provider wants, if the requester wants, they can receive an acknowledgement that the referral has been received. They can also, if they choose, find or receive an electronic automatic notification that the referral has been accepted or that it has been rejected and why it may be. It could be that the selected service provider doesn't have capacity, or the service provider simply doesn't have the eligibility criteria that the individual meets. So again, this system, besides identifying and tracking and recording activities of the patient or the client, their needs, the ability to create and route referrals, will also track the progress through that. The nice thing about the system is that once that service has been requested, accepted, provided, or if it wasn't provided, the system will capture and display that history. And there's more, but I'm going to try to move through it relatively quickly. This system will provide patients and clients notifications, reminders of their scheduled appointments. Now, this is assuming, of course, there's a means of contacting that individual. If they have a cell phone, we'll be able to use texting. If they're staying in a shelter or home where there is access to the internet and that facility is providing them access to information, not necessarily the portal, but the fact that they've just received a reminder, we'll be able to do those things through this system and try to keep those patients and those clients informed of where they need to be in order to work through the system and to receive services. The last couple of items that in a short list of many things these systems can do is that it will produce individual provider and organization level service reports and dashboards. So you'll be able to see how many patients you've had, how many services you've provided, at what location, how many times Mike Mote's been through your service. And this information, again, is available from the requester, from the service provider, okay, and from the health plans that this individual is a member of. And the last item that we wanted to talk about in terms of the basic capabilities of the system is the ability to provide an analytics platform that will let you do much deeper dives in terms of the population served, the capacities, the volumes that were utilized, volumes that were available, referral patterns, and any number of things. Again, that's generally at a high level what the system is capable of. What we want to do now is take a look at how you might use this system. If you're making a referral, if you need services for one of your patients or for one of your clients, within the system, you're going to be able to identify your preferred network of service providers or healthcare providers that you work with. While there might be 30 or 40,000 service providers in this directory, you'll be able to identify the handful that you use if you're a primary care provider, and you'll be able to select those by the types of services they provide. If you're a health plan, you'll be able to identify those community providers as well as the primary care providers that are part of your network, and they can be in there so that when you're looking for services or trying to track the services that Mike Mote sees, you don't have to fish through 37,000 entries. You can go through the 20 or 30 that you would routinely use. Once you've established that referral network, then you're going to be able to take a look at the search criteria or to configure the search criteria so that if you're able to send from your EHR, okay, the fact that you need housing for this individual, you should be able to do something similar to what El Rio does, is they actually generate an order similar to a lab order and then pass that to a system. So we'll be able to work with you, work with your HRs, work with your human service provider systems, and build the ability for the system to actually pre-screen based on your referral network, the providers, the service providers that would meet the criteria to provide the service you're requesting. Very sophisticated, a very short sentence that is, we hope, will be a very powerful tool to help you and to adapt those workflows to be able to use this new tool without really adding more burden to your staff in your office. The registered patients and clients and the that are screened for social risk and social determinants, okay, are also going to be in this system. Again, I mentioned it earlier, you're going to be able to register your patients, you're going to be able to screen them, you're going to be able to identify their needs, and all that's recorded in the system. And if Mike Mote is a new patient for you, or I haven't been in your office in a while, you may look into this system, or your EHR may query the system in the background and actually determine that 3 weeks ago, I was seen in another office, or I was receiving services, temporary housing or permanent housing, from another community-based organization. So you may not have to do that screening again. You may be able to use the benefits of a more recent screening that somebody else has done. In all of this, you'll be able to view the individual's history, both their screening and their services, as they go through, as you would use the system. The last couple of items, again, is the ability to search and select service providers, and then to create, route, and track service referrals. All of this will be driven for you by the system based on the network that you put in place, that you identify, the provider network, the screening that you do with your clients, your patients, and the request you make for services. Additionally, again, if a patient or if a client has the ability to receive notifications or reminders, if you record that as that referral requester, then the system will be able to keep that patient up to date on where they need to be and how and where services are available. And again, the system will do much more. This is just a highlight. Now, if you're providing services, in other words, if you're a community-based organization or you're a primary care doc that's getting a referral from a community-based organization because Mike Mote is there, I'm going to get some temporary shelter, but they obviously have discerned that I need medical attention. Those referrals will come to you through this system, and they'll be delivered electronically, either through a secure email message that would come to you through a direct secure email, or directly into your system if you have the ability to capture those inside your EHR or inside your community-based registration systems. You'll be able to see a person's demographic information, prior screening history, current service activities, okay, and their service history. In other words, if Mike's already receiving shelter and I've come in and I've requested it a second time, you'll see that I'm already receiving that and will be able to advise me that that is still available to me. Those kinds of things the system can help and hopefully reduce the amount of time that you're spending looking for my history and what I need. It'll also allow you to accept or reject referrals and then automatically notify the referring organization. It will also help you use the system to contact that individual. As we talked about earlier, or as I mentioned just a few moments ago, if the individual has the ability to be contacted through a cell phone or some other means, if that information recorded in the system, then you're going to be able to notify, as that providing service agency, the appointments for this individual, remind them of those appointments, remind them of where the service is going to be provided or where they can obtain it. It'll also notify the requesters automatically that that service has been scheduled, the appointment, or has been delivered. So it really has the ability to take a lot of manual steps out of the process and automate those for you, notify people, but still give you the control and options you need to not be inundated with superfluous notifications. Again, you'll be able to screen that down to the things that are relevant and important. And again, as a service provider, the system offers a lot more. What I'd like to do now is take just a few moments to talk about the timeline we're working on. Very simple diagram here. We actually started in January and actually back in December, shortly after Director Snyder announced the whole person care initiative. We started working, we put a work group together. We did some market analysis in the first quarter. We brought that work group together, and over the course from April through August, we actually looked at what are the needs. We have about 35 different organizations engaged in that work group. We used them and a focus group to define the requirements. We used those to develop an RFP, and we actually released that RFP in August. Actually, I think it was around August 24th of this year. We're now in the phase of evaluating vendor responses to those RFPs. And between now and February, We actually will identify the finalists, we'll conduct demonstrations and presentations of their solutions, and those demonstrations will be open to anyone, okay, within the healthcare community and the community-based organization community to monitor and actually participate in those demonstrations. Right now, we've identified about 50 individuals that will work with us on that. Once we select that vendor and get the contracting underway, sometime in February and March, we'll develop a complete implementation plan, including the plan for pilot sites. And those pilot sites will really be used not to prove the system works, but to identify the best practice for establishing those referral networks, okay, for these community-based services. And we'll run those pilot sites. There will be multiple ones between really March and July. And if things go as we anticipate, we'll start a general rollout in August. And it will take several months, if not a year, to completely roll this thing out across the state. The current status is, again, as I mentioned, we have a work group that now has about 40 members of it. They did define the requirements. We have released the RFP. We did pre-screen 8 vendors and looked at them very carefully and did release 8 RFPs, or did solicit 8 RFPs. We received 6 responses back, and we're now again in evaluating those responses. Next steps, we will complete that evaluation by about the 20th of this month. We intend to select 3 or 4 vendor finalists and notify them by the 23rd. We'll then schedule and complete the vendor demonstrations by December 4th. And then with that vendor finalist, we'll start working on the contracting. The intent is to have the contracting done by mid-February. And then again, as I went through in the timeline, actually start those pilot programs in March. At this point, we're completed. I'm done with my presentation. We are accepting questions. And again, you can enter your questions at the bottom of the screen. And I'm trying to open the window now and take a look at what we have.
Mike,
And the
do you
first
mind if I
question-
just, do you mind if I
sorry.
just add a closing comment to your presentation?
Please, please.
So I think Mike did just a wonderful job of really defining the parameters of the closed loop referral system. When you look at our whole person care initiative within the Medicaid program, and clearly much of this work will extend beyond Medicaid program and its enrollees, from my perspective, it's really a 2-pronged strategy. One is maximizing the benefit that we have available to attend to those social risk factors that may be impacting our population. But then with the closed loop referral system, and perhaps more importantly, connecting individuals to available services in the community. And so we've made a real concerted effort, as has Health Current over the course of the last several months, to connect with community-based organizations and to ensure that they're part of the conversation as we provide clinicians with the tools to better facilitate that referral to social service organizations. But I really do see it as kind of a 2-pronged approach, looking at the existing benefit and maximizing the existing benefit, and then creating that sort of connectivity to those social service organizations.
Jami, there's a question for you. How was Arizona able to determine the impact of social risk factors? 45% decrease in ED utilization, 46% decrease in crisis utilization. These figures are often very difficult to obtain and demonstrate to the community that the permanent supportive housing provides that direct health impact on members. In other words, how were you able to determine that there was this kind of impact?
Certainly. And so that information, the information supplied in the presentation today, came from one health plan, Arizona Complete Health. So it's one example of many that we have on hand. Our managed care organizations routinely track the impact of the work that they're doing around social determinants of health, including housing, and the impact on member health outcomes. In the case that I gave today, we were talking about 152 individuals. So the plan was able to track improvement in health outcomes for that cohort that they had provided permanent supportive housing services to. We have a lot of that data on hand and would be happy to share it. Again, that was one example. All of our health plans are actively engaged and are contractually required to engage in this type of work, and we would certainly be happy to share additional data if that would be helpful.
Okay, thank you. I'm going to take one of the very simplest questions. Thank goodness. Will the system be integrated into the existing Health Current portal? Yes, it will. And to integrate the solution into the HIE platform in two different ways. One of those will be the integration with our master person index or master patient index. We have about 13 million people in that file and identified with unique identities. So what we will be able to do is tie their medical record to their community services record. And those authorized to see the information will be able to see that Mike Mote, who my primary care provider is, the diagnosis I have with diabetes, congestive heart failure, whatever it might be, as well as see the services that I'm providing. So that integration with the HIE will bring those pieces together. That will also enhance the ability for organizations, providers to look at their operations and look at the demographics as well as the medical circumstances or conditions of the patients that are receiving those services to build profiles that might help them decide where services are needed or more capacity is needed, those kinds of things. So that is a very deep integration we're going to do. The second integration will be through the HIE portal, and that when you're using the portal and you look up Mike Mote, you will be able to also look up our service, my services, through the community-based organizations. So those encounters will be there, as will the medical encounters, the behavioral health encounters, and others within the community. Jami, any thoughts on that or comments?
I would just add that we really see the closed loop referral system as presenting a really incredible opportunity to us at the system level across the Medicaid program in terms of being able to look at those successful referrals that are captured through the system and look at the individual served and any change to their clinical outcomes. And so, you know, as we do this work, you know, we pursue the work around whole person care or social determinants of health, the real focus or the real purpose is around improving health outcomes, because we know that those social risk factors can have a dramatic impact ultimately on individuals' health outcomes. So with a closed loop referral system, we'll be pulling in data which allows us to see when and if individuals actually received services that met their social service needs, and whether those services ultimately had an impact on their health outcomes. So it really presents an incredible opportunity for us at a system level to track the efficacy of those social services that are offered to members.
Thank you. We have several questions we may not get to today. We will respond to all the questions, provide written answers, and post those. There's one last question that I want to read, and I will try to answer. The question is, we heard yesterday that the Arizona MAP program directory being updated and locally managed. Will that directory be a priority for inclusion in the tool? Certainly any service, any medical service, behavioral health service, substance use disorder service could be included in the system if those providers want to participate. We'll be open to them. and those types of referrals, the availability of that service. I will also let you know that at Health Current, one of our priorities on our roadmap for services provide is such a directory and a linkage between that and the HIE platform to allow people to identify where these services are available and whether or not their capacities. So we will look at this and work with Director Snyder, work with providers in the community to evaluate the best way to represent these services or to provide access and view into the capacity of those services. Director Snyder, we have a couple of minutes left. Are there any closing comments you have?
I noticed, I think, one other question that was placed in the chat. Hold on one second. Let me expand my screen here, which specifically asked about tracking chronic conditions. And I think the example was acute wound care and looking at type 2 homeless diabetics or individuals with diabetes with foot infections that might engage the ER. I think that's a great example of a data element that we may want to take a look at as we move forward, specifically, again, at the system level, but certainly our health plans as well. And so we can incorporate that information into future presentations. But I think there are a range of metrics that we'll be looking at in addition to the real basic metrics around ED utilization, readmission rates, access to preventative care that could be illustrative of our success again in connecting individuals with critical social services.
Great question and a great answer. And as I spoke a little earlier, the integration with the closed loop referral system and the HIE platforms through the MPI will allow this kind of tracking, this kind of analysis, because it'll bring the medical record in with this community service record and allow us to look at those patterns and look for ways of helping those individuals. At this point, again, we will get back to you with the answers to the remaining questions we weren't able to address during this session. And we'll now take a very brief break and get ready for the next session. So thank you all. Thank you, Director Snyder. And we look forward to working with Access as we go down the road together.